Well, thank you all for coming, and thanks, Charlene. First of all, I want to thank Marcus and Tom and Julie for really helping me get this together this morning. Let's see. So, yeah, we're going to talk about prescription opiate abuse and non-addictive chronic pain management. Just a couple disclaimers to start. I'm not funded by any pharmaceutical companies. I'm not a board-certified pain specialist. We're going to be talking about pain, but I'm not a board-certified pain specialist. I've been board-certified in family practice since 1995, so I've treated a lot of pain patients. And then I became ASAM certified back in 2006. And then when ABAM came around, the American Board of Addiction Medicine, you probably all know that there is an actual true specialty now for addiction medicine. Fellowship programs are starting on the East Coast, and it's its own true specialty now. So, you know, if you're wondering if a physician is knowledgeable about addiction medicine, the question now to ask is if they're ABAM certified. So I still do some primary care work, and I do quite a bit of urgent care work. So I'm kind of on the front lines of this whole prescription opiate situation, mess, problem. And then, of course, I do addiction medicine. I've worked in a hospital-based inpatient treatment program, doing hospital-based detox. I've worked in outpatient programs. I've had a private practice in addiction medicine, and then here at Alta Mira, residential treatment. Okay, so there are a few, if you want to follow along with your handout, because there are a few handouts that are not, I couldn't get them into the PowerPoint presentation. I'm not that savvy with PowerPoint and electronic media. I feel very constricted with all this. So the next page is on narcotic analgesics. So this is kind of what we're dealing with, this is what we're faced with. And this is just a partial list. So there are a lot of prescription opiates out on the market. So just a couple comments on this narcotic analgesic page. So there's opioid agonists. Some of them are long-acting, some are short-acting. We'll come back to that when we kind of talk about the treatment of acute pain versus chronic pain. So we have fentanyl, hydromorphone, meperidine, morphine, oxycodone. You'll notice this is it's important to understand that oxycodone is available in a controlled release tab up to those doses, up to 80 milligrams. I think we're probably all very familiar with OxyContin, with OC, and diversion of OxyContin and abuse and addiction with OxyContin. Then it's also in a short-acting, smaller dose oxycodone. The trade name is typically Percocet. So if you look at the doses of a typical short-acting oxycodone, it's like 5 milligrams compared to, say, up to 80 milligrams of a OxyContin tablet. The most abused prescription opiate is oxycodone in the United States, followed by hydrocodone. And that's both the higher dose, the longer acting oxycodone, and the short acting. So that's enough on that. Next page in your handout, again, I don't have a slide, is for you biochemists out there. I didn't hear anybody who was a biochemist. That's probably a good thing. Heroin, the other name for heroin is diacetylmorphine. So you can see its similarity to morphine. They're 5-ringed structures. Hydrocodone and oxycodone as well are similar in structure to heroin. Okay, so I'm ready for the next slide and the next page. Is the volume okay? Raise your hand if you can't hear me, right? Okay, so the way I kind of look at this when I think about patients or people taking prescription painkillers, I like to divide it up into three different groups. So the first group are patients that do not have any type of pain, physical pain. They're just strictly taking it for the mood alteration, to get high. So the trick is just getting those people to admit to their addiction, their abuse, and accepting treatment. Easier said than done. And then number two, we're going to kind of focus on this group more than group 1 or group 3 today, is there's a lot of patients that do have some level of acute or chronic pain, usually chronic pain. But, you know, hopefully you can get them to admit that they are abusing it and they're misusing the prescription opiate. So this is what we'll be talking about later on, about trying to treat those patients, because they do have some level of pain, but we want to try to get them off and away from the prescription opiates. And then the third group there are some patients that have chronic pain. They do not have any addictions. They don't abuse their prescription painkillers. And it sounds like most of you, all of you, really are in the addiction field. I didn't hear anybody strictly is in the pain field. And I think for those of us in addiction medicine, sometimes we get a little biased and we think anybody who's taking a prescription opiate's a drug addict. And then, so I think we do have our biases. And same thing goes for pain specialists. They don't think anybody's an addict. So we kind of need to try to keep an open mind, and I try to do that. And I have a slide later that kind of talks about how this group tends to be a diagnosis of exclusion. Like you just got to keep evaluating them, and as time goes on, okay, I don't see any evidence of abuse or addiction, and they're doing well in their life, and the medications are working. Okay, next slide. So I picked this topic because it's a big deal. It's in the news all the time. We only have about 35 minutes today, but I do want to leave 5 to 10 minutes at the end to hear your thoughts about prescription opiate addiction abuse. Okay, so abuse of prescription drugs. Try not to block here. Abuse of prescription drugs in the U.S. is common and increasing. In 2008, an estimated 4.7 million persons engaged in non-medical use of pain relievers. This number, a lot of you are probably familiar with this number. You see this a lot. It's almost 5 million people in 2008. In 2003, a U.S. survey of lifetime abuse of pain relievers was about 13% of the U.S. population. So in your lifetime, have you abused prescription opiates? 13% is not insignificant. And then last year, 2011 survey of U.S. adults reporting non-medical use, which I consider to be abuse, of opioid analgesics, 30.7 received meds directly from a physician. I don't know, this could be worse. It could be 70%. It's more like 70% of people abusing prescription opiates are not getting them from a doctor. It's not like I'm saying that that's fine, but it could be worse. Okay, 2005 survey of 50,000 high school students found a decline in the overall illicit drug use. That's good, over the prior decade. But non-medical use of pain relievers had increased, with 5.5% reporting misuse of oxycodone products. It makes me think of what you said, the 13-year-old? Yeah. Okay, next slide, I think. Okay, so this is going back to that 2008 figure of 4.7 million. To compare prescription opiate abuse with illicit drug use is a bit of an eye-opener. So heroin, 200,000 people in 2008 past month illicit drug use, compared to 4.7 million. And that, I'm sure that that's probably something that you guys are seeing. Certainly opioid-dependent patients that are coming here, the numbers are 6, 7, 8, 9, 10 to 1 prescription painkillers to heroin, at least in this facility. Cocaine, 1.9 million, hallucinogens, 1.1 million, inhalants, 600,000. So if you add up these 4 illicit drugs, they're still less than the numbers of prescription opiate abuse. Marijuana, we're not going to talk about marijuana today, but 15.2 million. So it really eclipses prescription opiate abuse. And then internationally, the International Narcotics Control Board estimates that 23,000 pounds of oxycodone were manufactured worldwide in 1998, but then in 2007 increased to 150,000. That's hard to picture. I don't know what 150,000 pounds of oxycodone would look like, but dump trucks full. In the U.S., We're in first place with the highest consumption of oxycodone in 2007. This is true for 2008, 2009. 103,200 pounds of that total 150,000, or 82% of the world total. That translates to 500 million, half a billion, 80 milligram, not the little guys, not the 5 milligram, the 80 milligram tabs per year. That seems a bit excessive to me. All right, next slide. Scope of the problem continued. So prescription opiate abuse, definitely in the news. Tip number 54, this is the last tip, TIP, Treatment Improvement Protocols. I don't know if you're all familiar with these. They come from the Center for Substance Abuse Treatment, CSAT, which is part of SAMHSA. And so there's now been 54 of these published. You can access these at the SAMHSA website. The other 53 tips, if you're interested, they all have to do with substance abuse treatment, diagnosis and treatment. The number 54, if you want to look at the next page on your handout, managing chronic pain in adults with or in recovery from substance use disorders. So this is hot off the press. This just came out. Tip number 54. And I printed it out. I killed a couple trees. I didn't realize how extensive this was. It's about 115 pages if you include the whole bibliography. And I left it at home, but it's this thick. So this is not a 5-page, blah, 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 treatment improvement protocol. It's highly readable. I did read the whole thing last week when I was in Hawaii. And it's excellent. So if you want to look at, what the experts in the United States are talking about treating chronic pain in substance abusers, this might be one of your better sources. And then ASAM came out with a public policy statement on measures to counteract prescription drug diversion, misuse, and addiction. You can find that there. I didn't want to print all this out and kill more trees. So that was just adopted by the ASAM Board of Directors January 25th of this year, basically talking about this is a huge problem. What are the things that we can do to try to decrease prescription opiate abuse, dependency, diversion? It's basically talks about education of doctors primarily. And then the CDC, I didn't go to the ASAM convention two weeks ago in Atlanta, but the CDC was there and gave a presentation called the CDC Taking Steps to Combat Opioid Deaths. You can access that, and that also, I put a little copy of that in your handout. CDC estimates that enough opioids were sold in 2010 to give every American adult a 5 milligram Vicodin tablet every 4 hours for a month. Calling interest in opioid abuse and death unprecedented in its momentum, on and on.
What that would do for Suboxone.
Let's see, in overdose deaths where a drug was specified, so this is any type of drug overdose death, illicit drugs, heroin, cocaine, any type of prescription or illicit drug, in those overdose deaths, 75% involve prescription drugs. It's not 75% of people with overdoses are dying from heroin now. They're dying from prescription drugs. And then of those deaths, opioid pain relievers were the cause of almost 75%. So that makes me nervous when I'm sitting in an urgent care and somebody comes in I don't know at all and they have a bad knee and they're asking for Norco. Okay, last one before we go on to this slide. A new powerful pain. We don't have enough, right? So let's get another one. New powerful painkiller has abuse experts worried from the Associated Press. So apparently there's a new hydrocodone. When I showed you one of those first slides, hydrocodone has always been combined with acetaminophen. And there's pros and cons to that. The idea is, well, okay, it's a kind of a weak painkiller. We have two painkillers in combination, try to help you with your pain. If you take I mean, it's good news and bad news. If you take too much of this, it's going to hurt your liver. So that's, in a strange way, supposed to decrease excessive use. We all work in addiction. That's not going to work very well. People do take 20, 30, 40, 50 Vicodin tablets, acetaminophen combined with hydrocodone, and they go into liver failure. And I think I certainly have had plenty of patients where that's happened. It's awful. So the solution, because we don't have enough, pardon my cynicism, we don't have enough painkillers out there. There's some drug companies that are going to make a new pure hydrocodone that's not combined with acetaminophen. And this doesn't say the dose, and I didn't look it up. I don't know what the dose is going to be, but it's probably going to be, it could be higher than the 5 and 10, the 2.5, the 5, the 10 milligram doses of hydrocodone that we're used to having. Okay, so next slide is here. Chronic pain is very common. Terry could confirm that. It's an aging population. People ages 65 and older who experience pain that has lasted more than 12 months, almost 60%. That's from the National Center for Health Statistics, and I got that from that tip, number 54. Okay, next slide. So I won't go into this too much, but I think you probably all know about scheduled controlled substances. This is good to know when you're talking to families and clients. So scheduled and controlled are synonyms. A scheduled substance is a controlled substance from the Drug Enforcement Agency and the Controlled Substances Act. So Schedule 1 means there's no current accepted medical use for treatment in the U.S. So an example would be heroin when we're talking about opioids. Schedule 2, current accepted medical use but high potential for abuse. Here's some examples. So when I'm in a private practice or urgent care, kind of wearing that hat, not wearing an addiction medicine hat, these would require a written prescription. You can't call it in, and you can't use electronic fax that we use in our urgent care clinics. It has to be a piece of paper, and the prescriptions are all designed to prevent photocopying and making adjustments. We'll look at that in a minute. And you can't have a refill without seeing the prescriber again and get another written prescription. So theoretically, this is to try to decrease diversion and addiction. So Schedule 3 has the current medical use, less potential theoretically for abuse. However, I mentioned before, the Schedule 3 meds of oxycodone and hydrocodone, at least the short-acting ones, are more abused currently than Schedule 2. And this probably has to do with prescribers out there having more willingness to write a Schedule 3 over Schedule 2. These can be phoned to the pharmacy, and you can actually give, I've seen this done, you can give up to 5 refills without seeing a prescriber. You can actually write 120 hydrocodone with Tylenol with 5 refills, and the patient doesn't need to come back for 6 months. Schedule 4, a little bit lower on the list, theoretically less abuse potential. Here's some examples. In the next slide. And then Schedule 5 is the last one. Again, less abuse potential than 1 through 4. Some of these don't require a prescription. They're over the counter, like Lomotil, which is really for diarrhea. And some liquid codeine cough prescriptions, that does require a prescription, but it's Schedule 5. And then we all know that there are some non-scheduled substances. They're not listed as scheduled or controlled substances, but they can be quite addictive in the right patient, such as tramadol, which is a partial opiate agonist, and then soma, which is an old muscle relaxant. Okay, next. So just a little bit about terminology. There's still a fair amount of confusion sometimes, especially, I wouldn't say so much with addiction professionals, like everybody in this room, but certainly with the public, and when you're talking to families, terminology can get a little confusing. So prescription drug abuse involves the use of a medication, usually by self-administration, in a manner that deviates from medical, legal, and social standards. That's kind of easy. And then according to DSM, use constitutes drug abuse when there's, you guys all know this, the abuse criteria from DSM maladaptive pattern, failing to fulfill major role obligations, legal problems, physically hazardous, or interpersonal problems. Okay, next. And then prescription drug addiction. Again, I know you all know the DSM criteria for addiction, for dependency. Addiction's not really in the DSM. Use the word dependency. Another definition, I'm sure you've all seen this, the 3 C's or the 4 C's or the 5 C's, a lot of C's. Chronic neurobiologic disease characterized by impaired control, compulsive use, and continued use despite negative consequences, and then cravings. This is important when you're talking to families. When I talk to families, physical dependency is not equivalent with abuse or addiction. Physical dependency is defined by tolerance and or withdrawal. And so that group number 3, the chronic pain patient that doesn't have any addictions, they are most likely physically dependent on their prescription opiate. That doesn't mean that they're addicted. And families kind of get confused on that. You know, Grandpa Joe is taking 6 Vicodin in a day, and you know, if he runs out, he goes through withdrawal, and so I think he's addicted. I mean, if he's taking it as prescribed and not exhibiting all the other characteristics of addiction, he's physically dependent, but he's not addicted. And then non-medical use comes up a lot in the literature. It's used for purposes other than that for which it was prescribed. And to me, that's abuse, that's misuse. Those are all interchangeable. Okay, next. I need 3 hands. And then more terminology. Some people kind of get very specific, and you know, they're kind of linguist purists about opiate versus opioid. All of this, as you know, comes from the opium poppy. I personally don't get caught up, and I kind of use the words interchangeably, opiate versus opioid. So starting to move into some pain terminology. For those of you who don't know, there's a concept, there's a clinical state called opioid-induced hyperalgesia. Hyperalgesia is an abnormally intense response to a normally noxious stimulus. I like that word, noxious. It sounds obnoxious. And so, you know, anybody would feel some pain if I pinched you really hard. Wow, I got 5 minutes. Holy mackerel. But people that have hyperalgesia, you just barely touch them, and they have, you know, an intense response to that. It's been, there's a lot of investigation around this, and it's thought that some opiates in some patients can actually induce hyperalgesia. So it's doing the exact opposite of what you want. It's not helping their pain, it's increasing their pain. So that's what OIH is. It's hyperalgesia that results from the effects of opioid painkillers. And then there's a term called pseudo-addiction. You should all definitely know that if you're assessing you know, pain patients that you're thinking may have some type of addiction. Because this is a term coined to describe aberrant drug-related behaviors that resemble those of patients with addiction, but actually result from inadequate treatment of pain. So if they're just, you know, they're having true pain, they're not getting enough medication, they can start doing some crazy stuff, trying to, you know, up to including stealing pills, you know, because they're in a lot of pain. Okay, and so this becomes a challenge as a treating provider. A patient comes in and says, you know, prescription opiate just doesn't seem to be helping. So there's 5 different things for us to think about. Do they have a worsening of their underlying pain condition? For example, worsening arthritic joint breakdown, and that's why they're hurting, and that's why the medications aren't working as well, because the underlying disease process is worse. Or have they developed opiate tolerance? The medications just aren't working as well. Or is this an addict who just wants another 20 hydrocodone or oxycodone? Or is it this opioid-induced hyperalgesia? The opioids are driving the pain. Thank you. And then number 5 is it pseudo-addiction? The patient's saying, I need more, because they do need more. All right. All right, so we'll go a little more quickly because I have to. So read the handout if you're interested. So basic review of CNS opiate receptors. There's different types of opiate receptors. The mu receptors, what these medications hit. There's a full agonist that stimulates the receptor in the cell, partial agonists like buprenorphine, antagonists like naloxone. If you overdose on opiates, naloxone, you can give an injection of that in the ER or anywhere else and try to save their life. Next. Okay, so just basics of kind of outpatient primary care, pain management. Talked about this a little bit before. Acute pain, we generally regard as less than 3 months. It's generally thought to be appropriate to use those short-acting opiates like hydrocodone on a PRN basis or scheduled. This is somebody who sprains their ankle. You give them a few oxycodone or hydrocodone for a few days on a PRN basis, and they're fine. It starts to become chronic pain after 3 months, and that's when you really kind of want to start rotating people to longer acting opiates and just schedule it. Start thinking about sending to a specialist. Okay, if you're evaluating a patient, again, family wants their 19-year-old daughter evaluated by you, is my daughter addicted to this stuff? If you're communicating with the prescribing physician or nurse practitioner, you want to hope that they're using this kind of stuff. Treatment contracts, which are also called opiate contracts, there's an example in the handout, are a very good idea. Urine drug testing, very good. Obviously, the doctor should be doing a good history, physical exam, trying to figure out what is the diagnosis. Use non-medication modalities and non-addictive meds first. Use the prescription opiate only if the previous methods are insufficient. Go through their substance abuse history. Try to get family and friends to help you on that. And then Terry, again, could talk a lot more about this, but the focus in chronic pain is on function rather than trying to eliminate pain entirely, right? Careful opiate selection, lowest dose, schedule 3 rather than 2. This is how people are dying, right? They're also getting a prescription for a benzodiazepine. They have some Ativan to go to bed at night or for anxiety, and then they take a few drinks and then they're dead. Ongoing monitoring, follow-up visits, urine drug screening. I do want to mention this. California does have a state prescription drug monitoring program, PDMP. There's the website if you want to check it out. I'm not sure if therapists can access this. Does anyone know if you can register? Well, you could check it out and find out. And it's called Cures. I actually don't know what that stands for in California, but that's what our program is called. And physicians then can access that. It still falls within HIPAA guidelines and laws. And you can find out if the patient has been going to other pharmacies and other doctors. You can get a list of all the prescriptions they've filled at a pharmacy. Now, if they're getting it off the street, this isn't going to help you. So these are pharmacy. And so I think this is very helpful. I just don't know if it's very widely used. I'm going to have to cut. Let's see. Let's just quickly go through. All right. Being a primary care provider, it's hard to do all that. We kind of went over groups 1, 2, and 3. Let's skip that. I just want to say that we are beginning our non-addictive chronic pain treatment program here with Terry and Sharon and other people that have been introduced already. So this is what we're really trying to go after. They have some degree of pain and usually a large degree of addiction. And we admit them for acute detox. We use buprenorphine, do this whole assessment. Next slide. As stated above, the ideal situation is to taper those patients off of buprenorphine. And I can't give you numbers on that. Hopefully in a year, if you come back for this lecture, we can really focus on what we're doing at Alta Mira and what's happening with our patients. But again, you want to try all these other medications and modalities before treat their co-occurring mood disorders. If they're still having severe pain, even though we're doing all of this, we will consider low-dose buprenorphine naloxone to try to help them with their pain if it looks like they're going to relapse to. I'd much rather have them do that than go relapse to God knows what. Wow. Okay. Do we have 2 to 20 seconds for any questions, comments.
Well, I've had several times now a situation where clients who have opiates with buprenorphine on an outpatient basis, but then of course the big problem is how to get them off the buprenorphine on an outpatient basis. Do you see that as difficult or maybe not even possible?
Yeah, it can be challenging. It has to do with, is there a provider that will follow up with them and see them and slowly taper them? It depends. It's like a lot of other medications. It depends on the dose that they've been on and how long have they been on it. And that sort of determines how long it's going to take you to taper them off. But I did have a private practice before in Sausalito, and 99% of the times it actually went smooth because I would see those people every week or more frequently if you needed to. We just had a patient here recently who absolutely wanted to be off from 32 milligrams. He came in at 32 milligrams of buprenorphine, and he absolutely wanted to be off in 35 days. And I said, I don't think so. We can try, because he really wanted to try, and it didn't go well. So it usually is going to take longer than that to taper off. So it can go smoothly as long as you have treatment providers that can follow up and monitor them. Yeah, well, so methadone can be used in a methadone maintenance clinic, right? Where you come in every day, usually getting liquid methadone. So that's that whole world. And then methadone now, can be prescribed for pain in tablet forms. And just about anybody with a DEA license can give methadone tablets. And that is, I didn't talk at all about methadone overdose, but it's a problem, it's an issue. I mean, are some patients doing fine on methadone for pain? Yes. Are some patients doing fine in methadone clinics? Yeah. So comparing that with buprenorphine, my personal preference, and I think there's scientific evidence behind this, is I would much rather use buprenorphine. Again, I don't want to use any opiate for pain if I don't have to. If we've done Terry and Sharon, we've done everything. They're on 4 lighted iron patches, the whole thing, and they're really at risk for relapse. And I would much rather use buprenorphine. I would never use methadone. I've never done that. I think it's too dangerous. Yeah. So first of all, I always go over with the patient. What do you want to do? Do you want to be on maintenance? And so again, we also have to distinguish whether this is like a group number one patient who doesn't have any pain.
These are just drug addicts that have no pain.
No pain. Okay, so we're talking about group number one patient, no pain. So, what's that? It's number one. So I talk to them. How long do you want to take this for maintenance? Well, first of all, do you want to be on buprenorphine maintenance, right? I basically it's just like anything else in medicine. I don't really make the decision on even hypertension with a patient. It's their body, it's their brain. They get to really make the decision for the most part. Again, I'm not going to give somebody abusive doses of some medication just because they want it. So if the patient wants to go on it, then I'll start to follow them and treat them. They need to be in treatment. You can't just, and I know this does happen, you can't just give a prescription of buprenorphine and say, okay, I'll see you in 3 months or a month. They need to be in, usually an outpatient program. So I've had patients take buprenorphine maintenance, group number one patient, up to a year. And I'm okay with that. I can live with that. Let's get you, your 1 year chip, and then let's really start trying to get you off. I just try to match it up with what's going on with the patient. If they've had 6 relapses when they were on buprenorphine maintenance, these clients will go off, come back and use their buprenorphine, that doesn't count. You need to get a real good, solid 1 year sobriety, in my opinion. So I can't give you a standard of care, this is the way it absolutely needs to be done kind of answer.
Hi, this question. I've seen a lot of research on mindfulness-based meditation practices used with pain. And, and I have had patients who say that they really want to control their pain only by that, and they can't. And how frustrating that is for people. And I just wonder what your experience has been combining mindfulness-based meditation, chronic pain patients and use of medication, or, how to navigate that. I don't know if you feel like...
I might turf that one to Terry. I can't, I've had like personal friends, I've done a little of my own mindfulness-based meditation. I don't have any chronic pain. So I've had personal experience with mindfulness. Thank you very much. If you have any other questions, I'll be up there. Thank you.